mwaka 85 nilijifungua mtoto wangu wa pili, ila sikubahatika kumpata, alifariki. Uchungu ulinianza usiku, nikalala nao, nikaamka nao, nikaenda hospitalini. Nilipofika hospitali wakanipima, wakasema mtoto amemaliza kufa. Basi wakaniambia kunifanyia operation. Baadaye tena ikashindikana, ikabidi watoe kwa njia ya kuvuta mtoto. Siku ya 3 ndio nikaona hiyo dalili tukaambizana na mwenzangu, vipi, labda twende wapi, kituo cha afya tutafanyaje? Kaambie kaenda. Nilipoenda akaniambia tiba ipo. Nenda wapi? Uganda. Tukaja kaulizana, sasa Uganda hatuna hela, tukienda Uganda huko tutafanyaje? Kwa kweli tukakosa namna, nikabaki tu hivyo hivyo. Kwa kweli kuanzia hiyo 2005 nikawa nayo hiyo hali ilizidi, ila sasa nikazoea tu. Sasa nikaona namna ya kukaa na huo ugonjwa, nifanyeje? Kazi zangu nikawa naenda kanisani, naenda kwenye mavikundi, naenda, ili mradi tu nikajua maana jinsi ya kujiweka nikaeje na jamii.
Fistula imemsumbua muda mrefu, tena kwa wastani ni miaka, lakini mimi nikamvumilia tu, tukavumiliana naye hivyo mwishowe mpaka tukaja kupata taarifa, bwana, mna habari? Bwana, fistula sasa hivi inatibika tena bure.
Tangu hiyo siku nimeshonwa, sikuona dalili yoyote mpaka nimetolewa mpira. Mpaka sasa hivi kwa kweli nashukuru sana, niko mzima na naendelea vizuri. Fistula inatibika na kupona kabisa sana, ninafurahi.
Okay. Thank you very much for a very good video. Good afternoon, good people. Good afternoon, ladies and gentlemen. I'm so excited and delighted to engage with you and welcome you to our webinar session, very incredible session on fistula, how to address fistula challenge in our settings. And I take this opportunity really to welcome all of you and thank you very much for joining our webinar session. So my name is Dr. Serafina Mpua. I'm the public health specialist and a medical doctor. I'll be moderating this session today. And I work here at Amref Health Africa in Tanzania as a program manager for reproductive, maternal, newborn, children and adolescent health. But I'm also a portfolio lead for women, youth, health and livelihood portfolio here at Amref. I take this opportunity to welcome all of you. I also oversee fistula program in Tanzania, which is implemented in the Lake Zone. So a few tips about our webinar. Please feel free to interact through our chat box. When you have any comment, when you have any question, please type in the chat box, and or you can raise your hand after during the question and answer session and share your opinion, your views, and your comments. In this webinar, we are going to have 4 speakers who will dwell more on sharing the experience from Tanzania intervention on fistula, but also from Uganda. But we will start with the opening remarks from our Country Director, Dr. Florence Tem, and then we will also receive a keynote address from Ellen Gambo, who is working with Amref Africa in UK. So our webinar title is focusing on addressing obstetric fistula in Tanzania, a multi-sectoral approach for sustainable solution under the theme of her health, her right, shaping a future without fistula. Main objective of this webinar is basically sharing experience, lesson learned, and best practices and innovation towards eliminating fistula in our settings as we move towards year 2030. The second objective is we are going to hear more on government priorities and policy commitment towards fistula prevention and treatment as we move towards, again, eliminating fistula in year 2030. So without any further ado, well, our main expected outcome from this session, we focus on increasing awareness of fistula, especially obstetric fistula, which is a devastating complication affecting women, especially after delivery following a prolonged labor or obstructed labor. We are also going to have a strengthened ownership by the government and the different partners and stakeholders in their efforts with alignment to government strategies and priorities towards eliminating fistula by year 2030. So without any further ado, I would like to take this opportunity now to welcome Dr. Florence Tem, who is going to give us a welcome remark and opening of our session. And Dr. Tem is the country director of Amref Health Africa in Tanzania, and she's a holder of medicine degree and public health specialist. And she's championed and advocated for fistula elimination into this country for more than 20 years. So please join me to welcome Dr. Tem to provide us a welcome remark. Please, Dr. Tem, I hand over mic to you. Thank you.
Can you hear me?
Yes, we hear you loud and clear.
Yes, we hear you, Dr. Tem.
Okay. So good morning, good afternoon, depending where you are in the globe. But thank you so much for organizing this session. And I wanted to share, I wonder if I'm able to share. I'm trying to share. Can you see it?
Not yet.
Okay. So maybe to begin with is just to understand what is Amref. I thought it's important to know who is Amref, and so that we can all understand why are we doing this webinar, much as it's organized by Amref together with our fellows from different other countries. So Amref, I don't know why can you see me? Can you see it now?
Yeah, it's coming.
Yes, it is.
All right.
Yes, yes, we
So,
can see it.
in the past years, it's gone again. Can you see?
Yes, we can see it.
Yes, we can see it.
Okay. So in the past years, Amref used to be known as an abbreviation of Africa Medical Research Foundation. But that abbreviation is no longer there. Amref is a name. And that said, it means Amref exists in a number of countries. And our global office is in Nairobi, but we have country offices like the one we have in Tanzania. We also have Uganda, Kenya, Ethiopia, South Sudan, to mention a few, but we reach over 35 countries in Africa. And we have different models of how we are structured. Like the one in Tanzania is a country-led kind of local registered. Also have Kenya, which is a local registered, and others who are remaining as part of the global office, but we're all operating under one entity, that is one Amref. So to speak, also have offices in the Europe and North America, which are more strategic office in terms of fundraising and global relationship. So it's good to know that much as we exist in different countries, we are affiliated in one way or another. So this map shows every country that we reach in one way or another, and we have some common program that we do across the continent, and fistula being one of them. So we have this strategy, and it's good for our audience to understand that Amref has been living with a vision of lasting health change across Africa. And currently we have a strategy that goes up to 2030, and we're standing on two, what we call strategic platform 1 and strategic platform 2. In these two strategic platforms, you realize in the first one, it's really about people-centered health systems and for sustainable primary health care. So as I go through, when I talk about primary health care, have in mind about obstetric fistula. So as we go through this PHC one, we are looking at promoting equitable access and utilization of innovative services at a primary health care level. And that's where we need to make sure that even obstetric care can be picked and addressed at the PHC level. Skills in terms of numbers, but also skills as well for the healthcare workers, but also community health system that can actually pick and detect and prevent fistula, but also be able to identify those who are living with fistula, obstetric fistula, and also financial part of it. But when talking about social determinants of health, which is our strategic platform 2, there are other factors beyond just medical and what means about healthcare services that surround people with who end of the day, they end up with obstetric fistula, but exposing issues around gender, which also goes together with some of the things I will not be mentioning here, but they're related, but also poverty and all things to do with the literacy. So why have I said this to start with in terms of understanding our strategy? We have been addressing obstetric fistula for many years. Ourselves in Tanzania since 2002, we've been doing this in a country, and we've been able to reach, I think there will be a presentation that shows the magnitude of effort we've done in the country, reaching over 12,000 beneficiaries. But we know each year, come 23rd of May of each year, we have International Day to end obstetric fistula. So the idea here is to end obstetric fistula. We may ask ourselves, what is it? And I think our presenter will tell us very well. We know it's a hole between the birth canal and the bladder, or birth canal and the rectum, but really it's preventable. And we know it happens because of prolonged and obstetric labor. And that means if we need timely intervention. But what we're seeing is really about awareness, knowledge, and maybe access to services on a timely basis. So there are a number of things that makes this thing continue to happen to date. And much has been addressing this obstetric fistula for a number of years. We are seeing that the cases are less, but now we are seeing those who are occurring because of skills of healthcare worker. We are calling them iatrogenic fistula. So it's estimated that at least 500,000 women in many countries, low and middle income countries, are faced with obstetric fistula, which could actually be prevented. And Africa carries more than 50% of the burden. That said, why are we addressing? I've already said our strategy tells us to do that, but also sustainable development goals, each one of them. And if you look at the sustainable development goal number 3, about good health and well-being, gender, poverty, inequalities, they all surround what we call social determinants of health around obstetric fistula. We know it's preventable if you look on the supply side, but also on the demand side. On the demand side means the people themselves need to understand and get away out of the delays that may happen out of decision to make where to deliver, birth preparedness, knowing that it's preventable, getting out of a myth so that we can go quickly and get start your antenatal attendance timely, but also have better preparedness. But on the supply side, to have a skillful personnel. During our training, we are told that you need to manage the 4 Ps, the passenger who's a child to be born, the powers of the contraction, but also the pathway where the passenger path is there, but also the psychology of the mothers during delivery. How much that's been monitored? So during this session today, we shall hear from our renowned speakers how we deal with those areas of delays, but on the quality of services at the health facilities, but also to make sure that the mother know where to get services. So in our topic today is about multi-sectoral approach. And why we're saying multi-sectoral, I've just mentioned the SDGs to do with gender dynamics, the issues of poverty, the issue to do with nutrition, there's literacy, myth and conception. All these need to be touched so that we address it holistically. So we need the role of our policymakers. We know our policies need to embrace obstetric fistula. I know in Tanzania we've been pushing to make sure that at least obstetric fistula is being mentioned in our roadmap. It's not yet there, but I hope it will be included, but also having social determinants of health being addressed in all policies, what we call health in all policies. So it's not just about the whole, it's not just about repairing the whole, it's a holistic approach when it comes to obstetric fistula. And it is really about everyone's responsibilities. So thank you so much, everyone, and welcome to enjoy our session. Thank you.
Thank you very much, Dr. Florence, for a very good opening remarks, which has dwelled on sharing our strategy, Amref West Africa, for 7 years, 2023, 2030, but you've also highlighted on issues around obstetric fistula in alignment with the SDG, multi-sectoral approach, but also a lot of policymakers and everyone engagement. So thank you very much. Now I take this opportunity to welcome Ellen. But at the meantime, I encourage participants, please, if you have any question, don't forget to type in the chat, but you can also write and later on raise the hand and share it. Now I welcome Ellen Gambo, who will give us a keynote address. Ellen Gambo is going to share with us some experience in supporting programs in Tanzania and Uganda, but also some opportunities, funding opportunities and challenges. So Ellen Gambo is a senior program and partnership officer who is working in Amref, UK. She has several program and fundraising experience. So now I take this opportunity and hand over to you, Mike. Ellen, please welcome and talk to our audience about the keynote address. Welcome, Ellen.
Thank you very much, Serafina. Let me just share my screen. Can you see that?
Yes, we can see that.
Great. Thank you so much. Thank you everyone for joining today. As I said, I'm Ellen. I'm the Senior Programs and Partnerships Officer at Amref UK. So today I just wanted to give a brief overview of Amref UK's role in supporting the fistula projects for just from 2019 to 2025 in both Uganda and Tanzania. Also give a little overview before the teams go into a lot more detail on the project objectives, and then just give some snapshots of the key achievements by both Uganda and Tanzania in the fistula projects. And finally, I just wanted to wrap up by looking at some of the funding challenges and opportunities that we're seeing for both renewing fistula, but also our other programs. So to just give a brief overview of how Amref UK has worked with both the Uganda and Tanzania teams in the fistula projects, and how we usually work with delivering other programs as well within the Amref network. The first one is, we manage the partnership side of things. So we develop and manage the relationships with the funders. So in this case, for the fistula projects, we have managed the relationship with an anonymous donor for about 6 years now. And that is just primarily our role to steward that relationship and steward the donor through from the start to the end of the project. Also, we support and collaborate with the country offices to ensure quality assurance and review any reporting and communications that go to the donor, and also ensure the donor requirements are met for each project. We also have the fund management, so managing all the funds from the UK that we raise out into the Amref network. And finally, and probably most importantly, we are the fundraising office, so resource mobilisation is key. So we raise both unrestricted and restricted funds for Amref programmes. So for the fistula projects, these were both restricted funds. So as I said, the project teams will go into far more detail.
Ellen, sorry to interrupt. Can you put it in a presentation mode, your presentation?
Oh, is it not in that?
It is not moving at all.
Oh, is it not? Hang on a sec. Can you?
It is still not in presentation mode.
How does it?
You need to click the presentation mode.
On the, sorry guys.
Below there on the right side. Yes.
Slideshow. There? No? I'll stop sharing.
Let us share for you, Ellen, please. Let us share for you.
Thank you.
Oh, I think you better show the presentation as we agreed, please.
Proceed.
Yeah. I was just on the next slide, please. Thank you. Sorry. So yes. So just to give an overview of the project objectives, as I said, the teams later will go into a lot more detail. So both Uganda and Tanzania, we have supported from Amref UK, both phase 1 from 2019 to 2022 and phase 2 from 2022 to 2025. And both these projects run concurrently with each other. So they are both funded by the same anonymous donor, and both receive £1.5 million in funding each. So they have the overall objective to improve health and socio-economic status of women who suffer from obstetric fistula. And the main difference is Uganda also provides support for other obstetric conditions. So just to do a quick review of the Tanzania objectives for phase 2 only, so that was mobilising community members and empowering health workers, scaling up surgical capacity for women living with fistula, providing psychosocial support and livelihood support, and also enhancing the data collection for future services and engaging with governments. And then for Uganda, slightly different, but the objectives were improve in community knowledge about reproductive and maternal health services, improving the capacity of health workers in fistula repair and management, providing holistic treatment to obstetric fistula and other obstetric conditions, improving the socio-economic status of survivors of obstetric fistula, and finally, again, supporting data collection to provide learning and share learning with local governments. Next slide, please. Thank you. So this is just a snapshot of the key achievements over phases 1 and 2 that the team have achieved from 2019 to 2025. So we've managed to achieve 1,140 fistula and other obstetric surgeries. And after we provide the surgery, there is a full follow-up care and socio-economic support that follows that. The team have also provided 150 fistula champions with training, and this has been really essential in identifying and mobilising potential fistula clients and raising awareness about fistula in the community. Also, the team have trained 180 health workers, which has been really fundamental in improving the prevention, screening and referrals of the fistula process. And from the learnings of phase 1, we have implemented into phase 2 only entrepreneurship training, where we've provided 70 clients with training from local training institutes. Next slide, please. And so with Tanzania, again, this is just a snapshot of the achievements, not all the achievements, but from phases 1 and 2 combined. So the team have achieved 389 fistula surgeries only. And again, same follow-up care with socioeconomic support followed after each surgery. The team have also trained 499 fistula ambassadors, which again is really critical in identifying and immobilizing and also raising awareness about fistula. As we said, we had implemented from learnings from phase 1 into phase 2, where now we provide psychosocial support with a local partner, which has been really critical to helping and addressing the needs of the fistula survivor, but also building the understandings of the families of what they've experienced and gone through. And finally, 345 clients have been provided with livelihood support, which is either seed funding or income generating assets such as livestock. Next slide, please. So before I wrap up, I just wanted to have a little overview from the fistula perspective in terms of funding, but also general programs of what we're seeing in the UK from the fundraising office perspective. Now, for this donor, we've been incredibly lucky for this fistula phases 2, 1 and 2 to work with the same anonymous donor who's donated very generously over the 6 years, but we're changing priorities. We're now looking for a new donor for a slightly more scaled down phase 3 fistula project. So these are some of the challenges that we're starting to see. So first of all, changing mindset. As we all know, there have been a big shift across the US and Europe in relation to international development, with, of course, the US aid cuts, but also in the UK, we have had the UK aid cuts, and a lot of the budget that remains with the UK aid is ring-fenced for refugee projects in the UK only, not to go out overseas. So the pots of money, government pots of money, have shrunk a little bit, we're seeing in the UK. Secondly, there's a bit of a poly crisis in the background, so multiple humanitarian, socioeconomic, environmental, political crises, which are creating quite a complex and challenging environment to fundraise
Ellen,
for.
you are remain with 1 minute to wrap up your...
No worries, I'll wrap up. So that's one. And then we've also been seeing narrowing pipelines, so funders choosing to maybe work with a smaller group of organisations than they were before. But to wrap up with 1 minute, to be a bit more positive, we are seeing some new opportunities in this changing environment. So collaboration and partnership, so more organisations open to collaboration and co-funding. Also, Amref, as we all know, is very best placed to lead programmatic direction, as we are African-led and a lot of other international organisations based in the UK are not. We're also seeing it as an opportunity to broaden our funder network. So it's giving us the opportunity to start thinking outside the box and maybe engaging with more corporates and research institutions. So with wrapping that up, just to say thank you so much for letting me speak, but also an opportunity that the UK is so proud to have been able to work with Amref, Uganda and Tanzania, who have done an incredible job in implementing the phases 1 and 2 of the fistula programme, and we're hoping that we will be able to identify some new funders to look at a potential phase 3 in fistula. So thank you very much.
Yeah, thank you so much, Ellen. Thank you very much for sharing with us your experience through Amref UK support to fistula program in Uganda and in Tanzania, but you've also shared with us some opportunities and challenging towards funding support for fistula as a way forward and potential funding support. So thank you so much, Ellen. Now I would like to continue to insist audience to continue, keep your questions and type in the chat if you have any question. But I would like to take this opportunity now to welcome the first speakers. I would like to introduce Dr. Phineas, who is our first speaker. Dr. Phineas Sospita is the head of Safe Motherhood Program Division from Division of Reproductive Maternal Child Health at Ministry of Health, Tanzania. He is an obstetrician and gynecologist with public health specialist, policymaker, and a researcher. Our second speaker is Gaspari Misungwi. Gaspari Misungwi is a project manager for Fistula project here in Amref Health Africa in Tanzania, and he holds a Bachelor of Community, bachelor degree in Population and Development Planning, and is the one who is overseeing and implementing this project in Geita and Mwanza. The third speaker is Emmanuel Ebitu. Emmanuel Ebitu is a Fistula project manager from Amref Health Africa, Uganda. He's a public health specialist and is also he has strength in health systems delivery and public health programming across Uganda. He has Masters of Public Health and the Bachelor of Science in Health Service Management and postgraduate in Diploma in the Project Management, Planning, Monitoring and Evaluation. So the last but not least is our very own Dr. James Chapa. Dr. James Chapa is a president of Association of Obstetric Fistula Surgeon of Tanzania. Is a highly experienced obstetrician and gynecologist with more than 12 years experience in clinical practice and specialized expertise in fistula surgery and training. So I also hold a Masters of Public Health. So now, having introduced our very own and experienced four speakers, I would like now to welcome Dr. Phineas. Dr. Phineas is going to give us overview of government leadership in advancing fistula care in Tanzania. Please welcome Dr. Phineas and share your presentation with audience. Karibu.
Good morning. In the team, as I've been introduced, I work for the Ministry of Health and the Department of Reproductive, Maternal and Child Health. And today I'm excited to share with you the government priorities as we aspire at ending the obstetric fistula in Tanzania. Through this presentation, I will share with you the national priorities and the policy framework, the policy alignment as regards to the WHO building blocks, challenges and opportunities, and at the end, I will conclude with the call to action. The incidence of obstetric fistula in rural resource settings, including Tanzania, is often difficult to ascertain. This is because most of the sources, they forget about fistula, which emanate from other etiologies apart from obstetrics, but also we still have a significant number of women who are underreported. But at least global, we can estimate around 130,000 new cases each year. And we classify this as a maternal mortality or maternal morbidity or near miss cases. And it's the same classification as we classify those who end up in ICU care. We estimate that unrepaired VVF cases with between 30,000 and 130,000 each year. And in Tanzania, there's around 1,800 cases of fistula each year. And some of these, they end up unrepaired because we know this is a disease of the poverty because of lack of funds and socioeconomic issues. Some of them, they still miss opportunities. Next slide, please. Yeah, just an example, in last year in 2024, we had a total of around 1,400 surgeries in Tanzania. 8% were supported and 12% were still did not receive any support, which means other part of the fistula management went without any recognition. And we have some of the facilities I've seen there who manage these cases, but as a government, we still see there is an opportunity to increase the number of facilities which offer this management. Next slide. Yes, so as the government, we have translated the global strategies from the regional and the global at large into the national guidelines. And specifically, we have the 1.3, which we call a national roadmap to accelerate reduction of maternal and newborn morbidity. But we also have the health sector strategic plan 5. And we also have the Tanzania development plan. All these plans, when put together, they address issues of quality of care as regards to maternal and child death, but specifically also to obstetric care in order to avert the obstetric fistula. And one of them is the maternal and perinatal death review and surveillance, where we review maternal deaths, but in addition to that, we also review the maternal near-miss cases, which also includes obstetric fistula. The aim is to identify dysfunctions around the management of difficult deliveries, obstructed labor, and the like, so as to set the mitigation strategies to avoid further damage. And the stakeholders in this group are all put together with other stakeholders in the Safe Motherhood technical working groups. But we also have other venues like technical working groups, group 5, where we meet other stakeholders from the sector and try to set interventions which are directed to improving quality of care and avoid the obstetric fistula. Next. Yeah, now the policy alignment and readiness to end fistula in Tanzania lies across the WHO building blocks. But just to mention a few within the health workforce, what we are doing currently, we are strengthening the competence for service provider, especially in the management of difficult deliveries. I mean the bridge presentations, the shoulder dystocias, and the like, so as to have the good outcome both for the mother and the newborn. But in terms of the service delivery, we are currently developing the costed national strategic plan, which will be guiding the planning, implementation of the obstetric fistula interventions. But in addition, the government is supporting initiative to prevent obstetric fistula and enable more women and girls to access quality of care. But of importance, we also support the development and functioning of appropriate number of health facilities to equip them with supplies and equipment to offer the good quality of care. On part of the HMS data indicators, as part of learning and research, we are informed by the data, and some of the indicators which we follow closer. One is newly identified obstetric cases, at least those who have surgical repair, but we also follow closely the number of fistula surgeons in the country as we aspire to meeting the expected need for the treatment and repair. But we are also following closely as an indicator the proportion of obstetric fistula repairs who end up with the definition of success at discharge and at follow-up. Yes, next please. Yes, so as I said, we are developing the National Obstetric Fistula Strategy, and it's currently under development with the vision of having Tanzania, which has a free obstetric fistula by end of 2030. And our mission is to protect and restore health and dignity of the most vulnerable women through prevention and treatment of fistula in Tanzania. We believe that if we have this plan, it can help us to objectively measure the progress so as we can make achievement by 2030. Next. Yeah, so as we all understand that fistula is a cross-cutting interventions involving many sectors, and its management involves prevention, treatment, but also the integration of women. Most of the women we see in the community, as it has been stipulated earlier, that treatment or success does not only mean closing the hole, closing the fistula hole, but also other parts of the management has to be taken care. So because most of the women come from the low socioeconomic activities, we need to have socioeconomic interventions which address other economic issues, and of course make them being reintegrated into their community after the long period of treatment, as these women undergo what we call obstetric fistula bad outcome complex. So we need to prevent, we need to treat, and make women reintegrated in their community after the long time of treatment. Let's go to the next slide. Yes, as we are continuing with this battle of ending fistula, we still observe some challenges. And one of the biggest challenges is having an increasing number of fistula, which emanates from inadequate surgical skills. When we do the maternal and perinatal death review and surveillance, we observe that most of the near-miss cases, they are quite related to lack of knowledge and skills among skilled birth attendant. Issues of management around difficult deliveries, including obstructed labor, they are not well taken care by our service providers. But also, as I said, success lies in the eyes of the beholder. When women are discharged from their facility, having their whole closed, but they still have psychosocial issues which sometimes they are not taken care well. But also, you may find that they are not being able to regain their menstrual cycles. They have not been well to be accepted again in their community. So I can say the partial implementation of the WHO definition of fistula, which needs to cover other parts of the management apart from surgery. But we also observe the geographical and financial barriers where some parts still have disruption as regard to the referral system from one facility to another, which contribute to the delays in receiving care. Cultural beliefs and stigma also still exist in some areas. In Tanzania, we still receive cases of female genital mutilation, which also contribute to the anatomical distraction leading to the bad outcomes. Of course, insufficient psychosocial support, it's obvious. And the opportunity which we see, one, we can leverage into on-job capacity building to equip service providers with sound knowledge and skills so that they can have ability to manage labor and deliver, especially the difficult deliveries of obstetric fistula, which is the culprit for fistula. But we also have opportunity when we have women at the antenatal care clinic, we can still teach them about psychosocial reintegration.
Dr. Phineas, you are remain with only 1 minute to finish.
Thank you. I'm just concluding. Yes, women have opportunity to be taught about psychosocial integration, but we can also foster about partnership and community engagement. Teaching about comprehensive sexuality education is very important so that to avoid early marriages, which leads to obstetric fistula. The next slide. Yes. As I said, having skilled birth attendant with sound knowledge will be an opportunity because if they are well equipped with sound skills, they can be able to manage labor and avoid adverse events, including fistula. Next slide. So, as I'm concluding, elimination of fistula is not only a public health initiative, but it's a moral obligation that demands urgent coordinated action. So we call upon partners from South, from North, East, and West to come together so that we can have communities that unite and invest in ending fistula. With that said, I thank you, moderator, and I hand over to you. Thanks very much.
Thank you so much, Dr. Phineas. That was very comprehensive, sharing from a range from policies, a range from different intervention and commitment that the government has put in place. You've also shared with us comprehensive management of fistula, from prevention, treatment, and reintegrating fistula clients back to the community. But you also shared the challenges and the opportunities, and you have called for action for different stakeholders, donors, and different parts to come together, much sectoral approach to addressing fistula. So thank you very much. Now I take this opportunity to welcome the second speaker, and this is none than Gaspari Misungwi, who will talk more and share the experience that Amref has taken through for the past 20 years in terms of prevention, treatment, and psychological support, as well as livelihood. And entrepreneurship support to our fistula survivors. So welcome, Ms. Ungwi.
Thank you so much, moderator, for the introduction. And of course, thank you all for joining. I'm excited to share with you our Impact 2 Decades journey of dedicated work in fistula prevention, treatment, psychosocial support, and livelihood empowerment for women who have been suffering from obstetric fistula in Tanzania. So next slide, please. This is my presentation outline, where we'll be looking at our 20 years journey of fistula project in Tanzania. We'll also be looking at our approach, which approach we are using. We have been using since 2002, best practices and lesson learned. We'll also be providing testimonials from our interventions, challenges and opportunities, and lastly will be a call to action. Next slide, please. Here is our journey as far as our fistula projects in Tanzania are concerned. As I said, for over 20 years, Amref Health Africa has been a leading force in the fight against obstetric fistula. And Amref has been using a holistic approach to ensure that obstetric fistula becomes a history in Tanzania by primarily preventing its occurrence, providing treatment support to women who are suffering from obstetric fistula, and ensure a seamless socio-economic reintegration of fistula survivors into their community. So these are the snapshot of the remarkable achievements that Amref has recorded. Amref has provided free surgical treatment to 12,707 women across the country. And in the next slide, you will see how we have managed to do this. Amref has also been able to train 199 healthcare professionals across the country. As Amref Health Africa Tanzania also has been able to empower 345 women on income generating activities as part of reintegrating these women back into their communities. So another remarkable achievement is the number of community members who have been reached through different interventions. Amref has managed to reach 780,503 community members through different interventions, and we'll see how we've been doing this in the coming slides. So it's not a one-man show. Amref has been working in partnership with the Ministry of Health, PRAJ, CCBRT, Bugando Medical Center, Mapelese, and other community-based organizations. So together, we have managed to achieve all this. Next slide, please. So I've prepared this presentation aligning it to the 3 pillars of fistula continuum of care, which actually addresses treatment, prevention, and the reintegration. So I'll be taking you through these 3 pillars of fistula management. Under treatment, which actually focuses more on restoring dignity and health, you can see the journey since 2002 to 2015. We have been able to provide free surgical treatment to 12,353 women. And this has been done through specialist medical service outreaches nationwide. This was a program which was covering the whole of the country. So we managed to reach a big number compared to the other phases that I'll be presenting through direct provision of free surgical treatment across phases, as I have reported. So in 2016 to 2017, we had a pilot project which was done in Imagu district, where we were able to provide free surgical repair services to 45 women who recovered from their traumatic obstetric fistula as well. And again, we had another phase which started in 2019 to 2022, where Amref provided free surgical repair to 191 women, and we worked together with the CCBRT. As you can see, 161 were done by Amref through Bugando Medical Center, and 30 women were provided with the treatment at CCBRT. And from 2022 to 2025, this is May data, Amref managed to provide surgical repair to 198 women, and this project is still ongoing up to October up to October 2025. Next slide, please. This is our implementation model, our approach. This approach basically falls under our fistula continuum of care, which actually emphasizes on the provision of a comprehensive holistic approach, that is treatment, prevention, and reintegration. So we have been working together with different partners. As you can see, we have the fistula ambassadors. We have a vast network of fistula ambassadors. As of now, we have almost 499 fistula ambassadors across the two regions, Geita and Mwanza, who are working to ensure that whenever the fistula survivors are identified, they are referred for treatment to Bugando. And also we have on board CCBRT, who are building the capacity of healthcare providers at Bugando. This falls now under the prevention part or the prevention pillar. But again, we have our partners like Mapelese who are doing the coordination role at the community level. They are providing awareness raising activities. They're also providing assets to the fistula survivors to ensure that they are fully recovered and reintegrated into their communities. We have also the government who are also doing the technical assistance to the project. And of course, we have underneath the regional social welfare, the district social welfares, RCDOs. We have also the DFFPs. These are district fistula focal persons who are also very instrumental in the provision, in the support of the implementation of the project. Next slide, please. Under the prevention pillar, which focuses more on stopping it before it starts, it is actually divided into two. We do intervene at the community level and also do intervene at the facility level, which is actually basically Bugando for now. And what we are doing there is to strengthen maternal health services to reduce obstetric complications through the support of mentorship and the coaching programs, which these are being done in partnership with the CCBRT. As I hinted before, we adopted a holistic approach, as I said, in 2002 to 2015. We are doing, we were providing these services through a specialized medical service outreach across the country. So especially in 2019, we adopted a holistic approach whereby we were now covering our patients with all the three pillars. The treatment, of course, we are doing also the prevention part of it, and we are doing also the reintegration, which actually has the three components, the psychosocial support and the livelihood support. So under the community, the more emphasis is put on the community awareness, strengthening community referral pathways, and training healthcare providers from at Bugando Medical Center to ensure that we provide quality services. So under the holistic approach, we do not only address medical needs, but we also address the psychosocial, community, and the systemic challenges that face these women who are suffering from obstetric fistula. The picture shows that we are on board. We are providing we are providing a fistula education to different communities that we work with. Next slide.
Thank you. Yes, Barry, you are remaining with the 2 minutes to conclude your presentation. Thank you.
Okay, thank you so much. This is typical integration and advocacy initiatives that are being done by the project. In phase 1, where that is counting from 2019 to 2022, we were able to provide psychosocial support to 191 women. And of course, the same number was provided with the income generating activities or income assets to ensure that they're fully integrated in their communities. In phase 2, we were able now to provide psychosocial support to 198, and 145 women have been provided with income generating assets to ensure that they are fully reintegrated into their communities. So on the picture, you can see it's the District Commissioner of Ukerewe District who is actually supporting the project massively to ensure that we reach more number. Next slide. These are some of the best practices or lesson learned as we implement different initiatives in the community. Empowerment, we are working with the women groups in the community, and this has demonstrated or it has provided us with a very good results, improves referral treatment access, but also strengthens community access and local ownership of the health initiatives. So we are working to ensure that every board is on, everyone is on board to ensure that we serve this community of women who are suffering from obstetric fistula. We have also the social behavioral change, whereby we engage local radios. As we will see in the next slide, we have a story of a mother who had an advert from the radio regarding the treatment, and she was able to access the treatments through radio. So with the engagement of radio has helped us to increase awareness and massive demand on fistula service uptake. Next slide, because of time. So here is the story of Joyce. Actually, she developed a fistula in 2024. This was February, where she suffered from an obstetric labor, lost her baby, and it's very unfortunate that she was even abandoned by her husband. But the thing turned into happiness, where we intervened in May 2024, where she was sent, in April 2024, she was referred to Bugando to access life-changing surgery. And now she's doing well as we speak. Joyce has never just ended there. Now Joyce is a local political leader and runs a soft drink and juice business. And she's a proudly champion. Fistula awareness, she provides fistula awareness, and she has already referred one woman for treatment at Bugando Medical Center. Next slide. We have another story from Clemencia, who actually survived with the condition for about 20 years, since 2004, but she received the treatment in 2024. As you can see now, Clemencia is happy on the photo, and she has been able to identify 2 fistula survivors and referred them to Bugando for treatment. Next slide. So here are the challenges and opportunities. Under the challenge, of course, the previous speakers highlighted on the issue of iatrogenic fistula. We still see the number is increasing. We have also been observing low knowledge and skills of screening and confirming obstetric fistula cases at lower health facilities. Also, low community awareness on obstetric fistula. Myths and misconceptions are still existing in the communities that we work in. Opportunities, there is an area of investment. In fact, integrating fistula services into maternal health programs is still needed in the community. Use of digital health tools, mobile phones for teleconsultation, appointment tracking, and the community awareness campaign. Another thing of the area that we can intervene or invest is based on community-based prevention and early detection, the leveraging of community health workers as far as the new program is concerned. Again, there's another area of advocacy with the local governments and other key players. Next slide as I conclude. Call to action, training more fistula surgeons and specialized medical teams is highly needed to ensure that we eradicate obstetric fistula as well as the iatrogenic fistula in our communities. Equip district and regional hospitals with the necessary infrastructure, and supplies is also needed to ensure that we provide quality services. Iatrogenic obstetric fistula integrate obstetric fistula into national health strategies is also needed, as well as allocating enough budget to support obstetric fistula interventions in Tanzania. So we also need to establish a clear referral and treatment protocols in maternal health systems, raise community awareness on the importance of early and consistent antenatal care. Lastly, investing in girls' education to delay marriage and pregnancy is one of the contributing factors to fistula. Thank you so much for listening. I beg to submit. Thank you, moderator.
Okay, thank you so much, Gaspari, for sharing the journey of Amref Health Africa intervention and how it has been collaborating with the government and the other partners. But also you've indicated number of surgeries that have been supported. And the most important one is how we've been implementing a holistic approach from prevention, treatment, reintegration, as well as psychosocial support to fistula survivors. So thank you very much. And now I would like to take this opportunity to welcome Mr. Emmanuel Ebitu. In the meantime, I continue to I continue to emphasize for participants, if you have any question or comment, please keep writing them down or put them into the chat box. Thank you so much, and please, Emmanuel, take over the stage.
Thank you, Dr. Sarafina, for the humble welcome, and a good afternoon to our listeners from Uganda. I'm Emmanuel Ebitu, the project manager of the Fistula program here at Amref Health Africa in Uganda. Next slide, please. So I will be sharing with you this afternoon the Amref Health Africa Uganda 20-year journey in fistula programming. We'll look at the approach we are using. We'll look at a couple of best practices and lessons learned. Then we'll look at a few community voices, the challenges, and then the call to action. Next slide, please. So the Amref journey programming in Uganda started way back in 2005. That is about 20 years ago. And the program was delivered mainly through the specialist outreach program here in Uganda, commonly known as the Flying Doctors, where the program particularly picked specialists from the national referral hospitals to deliver services within the district hospitals. In Uganda, we were able to work with 17 district hospitals located throughout their country. And through this program, we are able to reach 3,000, more than 3,000 women with corrective fistula surgeries. But most importantly, the first 6 pioneer fistula surgeons were trained with support from this program. Next slide, please. Over the years, we've done fistula work in other regions of the country through our Safe Motherhood Staying Alive program. We're able also to have fistula programming in the eastern part of the country, that is in eastern Uganda, from 2013 to 2016. Again, we are able to reach more than 300 with free corrective fistula surgeries. We trained village health teams, reaching more than 500. Particularly with information on the causes, the predisposing factors, and the dangers of obstetric fistula. But also we are able to build capacity of more than 500 health workers, particularly on comprehensive emergency obstetric and newborn care. Then we are also able to capacitate through equipping and supplies for most of the health center force that we work with. Next slide, please. Then between the years 2014 and 2016, through funding from MacArthur Foundation, our intervention shifted to Northern Uganda, where we provided 443 women with the corrective surgeries. We were able to build capacity for 152 health workers. The training mainly is on comprehensive emergency obstetric and newborn care, which is really key in prevention of obstetric fistula at facility-based level. Then we continue to build capacity of VHTs, where we reached 870 VHTs. Next slide, please. So then since the year 2019 to date, with funding through our Amref Health Africa UK office, we again undertook a program here in West Nile. We not now in Eastern Uganda, here in West Nile, where we work in 6 districts. Over the past 5 years, we've been able to provide more than 600 corrective fistula surgeries. We've supported more than 400 women through socioeconomic empowerment. We've been able to work with VHTs, reaching more than 180 VHTs, but also as well as build capacity for health workers. And then fistula champions, these are former clients who are fully recovered and satisfied. We engage them to be able to pass on the fistula messaging to the communities. Next slide, please. So quickly looking at the approach, the comprehensive approach, it's not different from the approach by the Ministry of Health in Tanzania, as well as the Amref programming in Tanzania. It has mainly 3 key intervention areas. We have prevention, then we have treatment and care, and then we have reintegration. Just to highlight at prevention, we have community-based prevention. This is where we reach the communities through health education and promotion, particularly providing fistula messaging through platforms such as mass media, but also we engage the community through community dialogues to address social determinants of health such as early marriages, teenage pregnancies, and school dropouts. Then at facility level, it's mainly building capacity of our comprehensive emergency obstetric and newborn care centers through equipping and building the capacity of health workers, because this is really key in the prevention of obstetric fistula. And then under treatment and care, we provide pre and post operative psychosocial support. Then, of course, we provide also free corrective surgeries. And then we also support the teams within the treatment hospitals with the required equipment and supplies. Then under integration, this is broad-based. We have the component of psychosocial support. We have the component of health, particularly messages and promotion of antenatal care, family planning, male involvement, which is really key in the prevention of obstetric fistula, but also the integration and the improvement of treatment outcomes for our clients. Then the other aspect, of course, is of the socioeconomic empowerment, where we support the clients to reintegrate, empower them in the communities through skilling, but also linkages to village loans and savings associations. But all these are hinged on, of course, promoting family planning, addressing social determinants of health, such as teenage pregnancies, child marriages, and then gender-based violence within the community. Next slide, please. Next slide. So some of the best practices are, as I mentioned, that treatment and care for obstetric fistula clients is not about the corrective surgeries, but rehabilitation at community level is key. Then initiatives that are aimed at preventing teenage pregnancies and increasing concentrative uptake, and then antenatal care, then hospital-based deliveries is also key in the prevention of obstetric fistula. Then it needs a strong partnership at community, district, regional, and national levels. Next slide, please. So this is one of our clients. She's called Grace, and I'll simply read. She says, "Now I can stitch clothes and stitch my dignity back. I dream of opening my own shop one day and helping other women who feel forgotten." This is one of the clients that has gone through the comprehensive programming that Amref offers to the community. Next slide. This is also another survivor whose life has been turned around, and now she's economically empowered. Next slide. So the challenges are not very different. At the comprehensive emergency obstetric and newborn treatment centers, there are still capacity gaps. And this is where it is key at level 4 in our case here in Uganda in the prevention. Then, of course, we still have issues with recurrence. Then there are still inadequate awareness in the community. And then, of course, infrastructure, because we are still using the camp model, the space, what space within the treatment facility is not adequate. Opportunities, we still can invest in capacity, building the capacity of these hospitals, both human resource and infrastructure through training, equipping, and supplies. Then, of course, male involvement is key. Then continuous messaging to the community through community engagements, dialogues, and meetings. Then partnerships, as I mentioned, at local and regional, national, and international levels. Next slide. Next slide. So call for action. This is my last slide, male involvement. This is key. And when we always interact with the community, we tell the men that the same passion before the pregnancy should be the same passion during the pregnancy, should be the same passion during delivery, and the same passion after delivery and beyond, if we are to improve the health outcomes for our mothers. Then, of course, the last one is on domestic financing. As we are aware, the funding landscape is changing, and therefore we call upon our local governments, we call upon our governments to increase financing, not only for reproductive health, but health in general. Next slide, please. Yes, thank you for your attention. Together, may our efforts continue to serve humanity for God and for my country, I see. Thank you.
Okay, thank you so much, Emmanuel. I really appreciate for keeping time, and thank you for sharing this experience from Uganda in terms of comprehensive programming for addressing fistula. And you have really showed the great work that you have been doing through specialist medical service outreach, care rehabilitation and reintegration. And you have really narrated very well on how prevention, treatment, and reintegration works in Uganda. I like the call for action in terms of increasing domestic financing for reproductive health, including fistula, but also health in general, and the fact that we also have to engage male involvement. So thank you very much. I continue to encourage participants to share your comments through chat, but I also see some of the questions, and I would encourage also the speakers who can start responding to the question through chats, and others will be responding later during question and answer. So now let me take this opportunity again to welcome the last speaker, Dr. James Chapa, who is also going now to turn the direction from obstetric fistula to iatrogenic fistula, which somehow Dr. Phineas also mentioned as one of the challenge, which is really upcoming currently in addressing or eliminating obstetric fistula towards the year 2030. So Dr. Chapa, the mic is yours.
Thank you very much, moderator. I'm from the Association of Fistula Surgeons of Tanzania, and I will take you through this very important discussion about iatrogenic fistula. And this is important because we are in a mission to end obstetric fistula by 2030, but now we are seeing iatrogenic fistula as one of the barriers that maybe is challenging our mission to end fistula by 2030. So we need to act urgently in order our mission to succeed, ending fistula by 2030. Next slide, please. Next slide. What is happening? Okay, thank you very much. So on discussing about iatrogenic fistula, I will take you through an introduction, and then we will see about the trends, the causes and predisposing factors for iatrogenic fistula, but also what does it imply to have iatrogenic fistula as one of the causes of fistula to women. And then lastly, I will talk about what can we do to end or to reduce the number of iatrogenic fistula in the fight against fistula in Tanzania. Next slide, please. Now, when we talk about iatrogenic fistula, these are female urogenital fistulas that are a result of an error or a fault during surgical or radiological intervention. So in female urogenital fistulas, we have many causes, but two main causes are one, obstructed labor, and two, iatrogenic causes. So with obstructed labor, we get the type of fistulas that we call ischemic fistulas. A woman is in labor for a long time of period. The urogenital tissues becomes necrotic and a woman gets a hole, that results into leakage of either urine or stool or both in some women. So with iatrogenic fistula, the hole is not caused by obstructed labor, but by default during surgical or radiological intervention. So iatrogenic fistula, like the fistula caused by obstructed labor, they don't only cause physical concern to women, but also psychosocial, economic, and other concern to the patients, the family, as well as the community. Next slide, please. Now, in lower and middle income countries, it is estimated that 2 million women are living with fistula. Of course, this is both fistula due to obstructed labor and fistula as a result of surgical or radiological interventions. And annually, the incidence is between 50,000 and 100,000. When you look back in 2015 and years back, almost 90% of all cases of fistula were due to obstructed labor. But now the trend is changing. We are coming from 10% of fistulas resulting from surgical radiological interventions, the iatrogenic fistulas, and now the trend is changing and we are seeing more of iatrogenic cases at the moment. Next slide, please. Now we have data that were analyzed for fistula cases that were treated between 2016 and 2021. From this data, we'll see the causes, the predisposing factors, areas where the injuries are occurring, as well as the regions where most iatrogenic fistulas occur in Tanzania. Next slide, please. Yeah, so if you look at this trend here, you can see the alarming, what I call an alarming rise in iatrogenic cases. I said before, 2015 and years back, we had only 10% of cases of fistula from surgical causes. But now you can see in 2021, the rate had, we had 42% of fistula in Tanzania as a result of surgical interventions, those iatrogenic cases. So you can see the graph here showing a rise in these cases. And as I said before, if we don't urgently intervene, this can be a barrier to end fistula by 2030. Next slide, please. So what type of procedure or surgery cause most of the iatrogenic cases? You can see cesarean section is the leading. More than 2/3 of all iatrogenic cases are caused by cesarean section, 61%. Of course, hysterectomy and other pelvic surgeries can also contribute to iatrogenic injuries causing iatrogenic fistulas. Next slide. Now, one of the predisposing factors to injury in pelvic surgeries, especially during cesarean section, is when labor has prolonged. But you can see here, 70% of iatrogenic fistulas occurred in patients who were in labor for less than 24 hours. That means majority of iatrogenic cases in cesarean section are occurring in women who are not had prolonged labor. So you can see maybe here we are dealing with an issue of skills. If a woman is in prolonged labor, yes, a fetus can go deep into the pelvis, and then during cesarean section, during that surgery, it sometimes brings difficulties in extracting the baby, and therefore one can cause injury during that procedure. But here, most women had injuries when are in labor in less than 24 hours. So we are somehow thinking of skill issue as an issue in this case. Next slide, please. Yeah, also another predisposing factor for iatrogenic injuries is the previous operation. If a woman has had other operations previously before the current operation, the operation that caused the injury, then there's a high chance of injury to the current surgery. But if this is usually if this is a new operation, that means this woman never had a surgery before, then the chance of injury is minimal. But if you look at this figure here, the first surgery almost caused 64% of the injuries. This is also against the normal risk in terms of previous operations and the complications in terms of causing injury, as when there's first surgery, usually the chance of injuring an organ is less. But here, 64% of injuries occurred in a first surgery. So this also points to an issue of skills to our surgeons. Next slide. Yeah, so you can also see here, most of the injuries occurred in district hospitals. And we know that in district hospitals, this is where our junior surgeons are posted. Just after internship, they are posted to district hospitals. They are not experienced enough to work independently. So this is why majority of injuries are occurring in district hospitals, almost half of the injuries. So this also points to an issue with skills. But iatrogenic injuries can occur at any hospital. As you can see, 2.1% of injuries occurred in a national hospital. Next slide. Yeah, of the structures that are injured during surgery, ureters are mostly injured. Ureters are the tubes, the pipes that drain urine from the kidneys into the bladder. During surgery, these are structures that are mostly injured. You can see 35% of all injuries occur in ureters. And this is important because the injury can include cutting of the ureter or tying it. And tying is very, very dangerous because when both ureters are tied, the chance that you can also injure the kidney is high. And this woman can not only suffer from ureteric injury, but also death from kidney failure. Next slide, please. Yes, and from our data, Dar es Salaam was the leading region in terms of iatrogenic injuries, and Rukwa was the least in the 7 topmost regions that were affected by iatrogenic injuries. Next slide, please. Now, what does this imply? What does the rise of iatrogenic fistula implies? Of course, one is surgical safety system failure. So we are dealing with gaps in terms of skills, gaps in terms of healthcare workers, numbers, of course, as well as the quality of our healthcare workers. We also have gaps in infrastructure, equipment, materials. If you're working or you're doing an operation with a dim light, there's a high chance of causing an injury. If you are doing your operation with blunt instruments, there is also a chance of injuring a structure. So these gaps may also means that the increase in iatrogenic fistula. So surgical safety system failure may be an implication to the rise of iatrogenic fistula. Number 2 is iatrogenic fistula implies that we now have double burden of etiology of fistula, that is fistula resulting from ischemia, that is obstructed labor, and fistula resulting from surgeries. We also have now a challenging situation. A rising iatrogenic fistula implies that we have now a challenging situation where vaginal delivery leads to a fistula, that is an ischemic one, and a surgical delivery leads to a fistula, another fistula, that is iatrogenic one. And another implication is that we now have a more difficult fight against female genital fistula because we have now ischemic as well as iatrogenic fistulas, and therefore we need more resources in terms of financial resources, but also human resources. Next slide, please. Now, what can be done? One is prevention of unnecessary cesarean deliveries. 2, we need to have protocols, training, competence checklists in order to make our surgeries safe. We also need competence-based surgical training, mentoring, and ongoing supervision, especially for our junior doctors. We need also to have accessibility of delivery services that are well equipped with adequate staffing, infrastructure, essential supplies to ensure high-quality emergency obstetric care. We also need to have working referral systems. A woman in labor, if a lower health facility cannot take care of this woman, a prompt referral should be made, and if this woman reaches where she can be helped in order for her not to get a fistula. But we also need a community level interventions. Community and family preparedness is also important. Next slide. Now, this is my closing statement, that iatrogenic fistulas are not accidents. They are failure of systems, as I explained before. Now, if we want to end fistula by 2030, let's transform surgical care through training, education, transparency. Let's call a spade, and this will help us really prevent the alarming increase of iatrogenic fistula, and hence reduce the number of fistulas, because by 2030, we, as per UN resolution, we need to have 0 new fistula cases, but the prevalent cases, at least 80% of them to have been treated. Thank you very much, Dr. Serafina.
Okay, thank you so much, Dr. Chapa, for sharing with us this very exciting presentation about the emerging fistula, none than obstetric fistula. And these are iatrogenic, which, as you mentioned, they're not accidents, but rather a failure of system. And you have really emphasized on issue of competence, skills of the surgeons who are providing these fistula surgeries. I mean, providing different surgeries around this area, so that to prevent this kind of fistula. And you have also emphasized on if we are really aiming at eliminating fistula by 2030, then we also have to intervene this emerging and upcoming iatrogenic fistula. So thank you so much, Dr. Chapa. That was very useful and helpful and very informative. So now I see a lot of questions from the chat and from the question and answer. And I would like to take this opportunity really to thank all the audience for your endurance, for really keeping engaged in this presentation. And thank you so much for your questions. I see a lot of questions. So maybe we start with the questions from the questions and answer, and I will allow our speakers to respond for those which have been directed directly to the speakers. But I'll also again move to the chat and check for the questions and comments, and also allow the speakers to respond to that. Please continue to write in the chat, but you can also raise the hand if you want to speak. We have some few minutes, and thank God that we have been able to reserve some more minutes, then we'll be able to respond, to have a good discussion to that. Please, for the questions, be brief if you are going to raise your hand, but also for the speakers, please be brief in responding, but precise to the point. So from the questions and answer, I see Robert Hiza asking Dr. Phineas, Dr. Phineas, where are as country in policy change for fistula-free generation in Tanzania? The second one is what is remaining gap we should address in fistula project areas, and this goes to Gaspari. The other question goes to Ellen. What and how makes Fistula Project Tanzania unique from Uganda experience in terms of data, implementation and effectiveness? And the other question again goes to Gaspari. Please highlight all behavior change components included in Fistula Project in Tanzania. Well, the one from Anonymous says, while you do a good job, not highlighting your success makes it seems like little is being accomplished. I often come across your social media updates which mostly feature meetings and a commemorative event. I believe there should be more focus on storytelling and presenting your achievement creatively. Kudos to the project team for their effort in front of the success, but I think the media department should invest more in creativity to effectively showcase the remarkable work Amref is doing on fistula repair in Tanzania. That was a comment. Thank you, Dr. Chapa, for a very informative presentation. I'm interested to know what efforts are currently being taken to mitigate the burden, knowing the prevalence is steadily increasing. And another question from Wida. My question goes to Dr. Phineas from the Ministry of Health. What steps is government taking to make sure that all midwives, including those still in school, are being trained on and oriented on the new labor guide now that country has moved from use of pantograph to the labor care guide? I'm asking because the labor care guide is proved to be more effective in monitoring the progress of labor, including prevention of obstetric fistula. The last one from Anonymous, what factors could have contributed to the increase in percentage of iatrogenic fistula cases in Tanzania from 2016 to 2021? I think this goes to Dr. Chapa. If I move to the chat box, I hope speakers, you are keeping up your questions. Looking at the chat box, I see, there is a question for Dr. Tem. Which determinant of health we should prioritize to address? This comes from Robert Hiza. And where are we as a country in policy change for fistula-free generation in Tanzania? This goes to Dr. Phineas. And what is the remaining gap should we address in fistula project areas in Tanzania? This goes to Gaspari. Please, speakers, you keep those questions and then we'll respond. What and how makes fistula project in Tanzania unique from Uganda experience in terms of data implementation and effectiveness? This goes to Ellen Gamble. There's a number of congratulations from participants. Again, Robert asked, please highlight all behavior change components included in the fistula project in Tanzania. This goes direct to Gaspari. Samuel asked, says most fistula campaigns are driven through camps. What opportunities exist to implement fistula intervention in health facility costs effectively? This is, I think, goes to either Emmanuel. Another comment says, kindly confirm whether after 20 years, Amref still faced awareness and the capacity gaps in Uganda. What were the key drivers behind this? This also goes to Emmanuel. The other comment, well, Dr. Phineas, I think, has responded. Says, thanks for the question. We acknowledge WHO recommendation on improving labor outcome by using labor care guide, and the government has employed a phased rollout plan for labor care guide as we continue to learn about it and its outcome. We currently training service provider and tutors in the college and university part of Scale Up. Well, there's another question which asks on factors which could have contributed to increase in percentage of iatrogenic fistula. I think this is similar to the other one from the question and answer. Dr. Rita says, after 2 decades in Tanzania, what is Amref showcasing a key advocacy agenda in shaping fistula service in Tanzania? And that will fast track ending of obstetric fistula. This goes to Gaspari. I see response from Dr. Florence for Robert. Says these range from socioeconomic, cultural, environmental determinants to touch on education literacy to avoid early pregnancy among teenagers, understanding importance of ANC attendance, institutional delivery, birth preparedness, and nutrition literacy, poverty, geographical barriers that affect access to health facility for safe delivery, gender equality, decision-making, where to deliver, adequate resourcing, and qualified, ethical, and skilled healthcare providers. Well, another question asked on kindly, can I get to know strategies that are being made to train these junior doctors so that we can reduce burden of iatrogenic fistula? And the other question, I think this is the last but not least, what are the strategic direction that Amref is taking to really end fistula after 2 decades journey? A lot of has been done, but gaps still exist. So now I want to ask our first speaker, Dr. Phineas, to respond to the questions, and then we'll follow the Gaspari, and then Emmanuel, and then finally we'll hear from Dr. Chapa. Please keep your questions and respond directly to the questions which were directed to you. Thank you so much. Please, Dr. Phineas, welcome.
Thank you, moderator. And I've got 2 questions from the audience. The first question about the labor care guide, I've just responded in the chat box, but just in brief, we acknowledge that the WHO recommendations on using the labor care guide has a good outcome both for the mother and the newborn. So we embrace the recommendations, and we have started rollout by training some of the TOTs in some regions, and teaching the tutors in the college so that even those who are in the pre-service can get knowledge on how to do the labor care guide. So we are just doing the phased rollout as we are continuing learning on its effectiveness on the mother and the newborn outcomes. And the second question was on the policy change as regards to the free provision of service delivery in the maternal health services in Tanzania. Of course, that may be beyond of my capacity to answer that big question, but even the maternal health services which we stipulate in the policy document, its implementation has been surrounded by many of the challenges, but we consider obstetric fistula as one of the important interventions. And to start, we have included that in the RM1SH interventions. As we all know that previously this intervention was seemed to be nowhere, but currently it is being managed at the Department of Reproductive, Maternal and Child Health, and we are still looking for resources, if possible, to make this intervention at least free delivery of service, to be delivered free of charge, so that many women can get benefit from these services. I think those were the questions directed to me, and over to you, moderator, for other speakers to respond.
Okay, thank you so much, Dr. Phineas. Now I would like to welcome Gaspari to respond to your questions directed to you.
Thank you so much, moderator. Of course, I have several questions. Maybe to start with the one that was posed by Robert. What is the remaining gap we should address in the fistula project in Tanzania? Of course, based on the experience that we can share from the 2 regions that we are currently supporting, Geita and Mwanza, there is still a gap at community level and a gap at facility level. And that's why there was a call for maybe for another phase to strengthen the capacity of healthcare providers at the facility level, because we have been also updated on the increase in iatrogenic cases in these 2 regions as well. So more is needed because there is a gap now, especially on the skills of healthcare providers. So much is needed, especially on building their capacity to provide quality obstetric care services in their respective facilities. As we have seen during presentation from Dr. Chapa, the iatrogenic cases are not only coming from the lower health facilities. They are also coming even from the zonal regional hospitals. So much is needed to intervene so that we can do away with that such increase in iatrogenic as well as obstetric fistula, as we still experience the cases are coming. But again, on the community, of course, more community education and empowerment is needed, as we still experience low knowledge, myths and misconception on fistula and its management. And this is coming from the communities that we serve. Geographically, Mwanza and Geita regions are huge, and they have big population, huge population. So more is needed to ensure that this public education reaches to those in the remote areas as well as in the other areas that are being isolated somewhere there. But again, there's a gap on advocacy. Of course, this is another question that Lita has asked. More strategic engagement is needed again to destigmatize fistula and to promote maternal health rights. And this includes allocation of adequate budget or funds to support fistula interventions in the country. So we need to have more funds to ensure that fistula interventions are being implemented fully, to ensure that now when it comes 2030, we are ending obstetric fistula in Tanzania. There was another question from Robert on social behavioral change communication, that what components are included in our interventions. Maybe I can just respond here. Through our project, we have been using SBCC campaign. This includes radio adverts, jingles that have been developed by the project in partnership with the Ministry of Health, and they were approved to be used. So we are engaging these local radios to air fistula messages, which actually, as I have reported during my presentation, it has given us a very good outcome when it comes on the awareness raising and the number of cases that are being referred to Bugando through this intervention that we intervene in the community. But again, we have also documenting testimonies as those ones that have shared the success stories, documentaries that are there on YouTube, on our social medias. You can see those are all those materials that are really helping in the social behavioral change communication in the community, plus our social media platforms that are being rolled out by the organization. So maybe those are the few things that I can highlight. And there was another question posed by Dr. Rita. What is Amref?
Please make it brief so that we allow other speakers also to respond. Thank you.
Okay,
Gaspari.
Thank you, moderator. There was another question posed by Dr. Rita. What is Amref showcasing as a key advocacy agenda in shaping fistula services in Tanzania that will fast track ending of obstetric fistula in Tanzania? As I have said, we are implementing these projects in Tanzania. We are implementing in partnership with other partners, and we have been posing different advocacy initiatives. I can just share experience of one district that we are working with in Geita region, Nyang'hwale, where we did an advocacy. We had an advocacy agenda there. We sat with the local government authorities, and of course, we discussed on how they can sustain our project. So they have been able now to allocate funds to ensure that all fistula interventions in the districts are implemented fully, to ensure that these women who are suffering from obstetric fistula are receiving treatment timely, and of course they are fully integrated in the community. So they allocated the funds, which now enabled the district fistula person to have a motorcycle that will enable him to travel in different parts in the district to ensure that he provides information regarding obstetric fistula and other related conditions to women and to the entire community. So this is one of the things that we are now starting to see in different parts of the district, including the Misungu district, where they have allocated also the same amount of funds to ensure that they provide quality services to the fistula survivors. So we have been seeing this in different districts that are being implementing, allocating funds to support fistula intervention in their respective districts. Thank you.
Thank you, Gaspari. I encourage other speakers also to write in the chat box some response. But now I would like to welcome Emmanuel Ebitu. Please, very briefly, go to the point with your
Yes,
response.
thank you. From Dr. Rita, after 20 years, so what next? I'm here at Amref Health Africa in Uganda. We are a member of the Fistula Technical Working Group, and the National Obstetric Fistula Strategy is now moving from providing fistula services through a medical camp model to routine. So in the next few years, maybe 1 or 2 years, the regional hospitals will be equipped with the necessary equipment and supplies for fistula repairs. So we anticipate to start having routine repairs done at the regional referral, and this will be cascaded to other health facilities. Then, of course, this tags to the question of the camp model. Yes, the camp model is quite expensive, and it is being done due to human resource technical gaps. But as I already mentioned, the National Obstetric Fistula Strategy, we are moving from camp model to routine, but starting with the regional referral hospitals. Then last but not least, in terms of after 20 years, we still experience capacity gaps in terms of human resources. That is mainly attributed to health worker attrition, but also most importantly, interest, because we have fellowship programs, but it's difficult to attract medical officers, particularly to go for training in fistula surgeries. Then the other final one is on awareness. Of course, awareness communities keep on evolving, and they are deep-rooted social-cultural beliefs that take a while to address, but also coverage. We are not in all the districts. Thank you. And over to you, moderator.
Thank you so much for being very brief and straight to the point, Emmanuel. Now I would like to welcome James. Dr. James Chapa, please. Again, I give you 1 minute to respond to the questions directed to you.
Thank you very much, moderator. My questions were 2, and one was about strategies to train. Yes, the Association of Fistula Surgeons of Tanzania, collaborating with other stakeholders, we are planning, of course, we are at a stage of proposal writing so that you can start safe surgery training. But there is one partner who is doing safe surgery training project around Lekki Zone. And I'm sure there is also programs from the Ministry of Health that is doing the same. So there is a lot of projects and programs that are geared into safe surgery training so that you can reduce iatrogenic cases. And there was a question from Rahma, what factors contributed to increasing in percentage of iatrogenic cases? Yeah, of course, from the data, the most important factor was skills, but we know there could be other factors. We think, of course, issues of infrastructure, issues of sometimes ignorance, not following the standard operating procedures, protocols, and available checklists could also contribute to an increase in iatrogenic fistula. Thank you very much, moderator.
Thank you so much, Dr. Champa. Now I would like to welcome Dr. Florence. I see there was a question on social determinants for health. Please, Dr. Florence, welcome.
Okay, thank you. I tried to respond on the chat because I am cautious with time. But the point is, talking of determinants, they do range from some of the social determinants. We mentioned about who's making decision, academic, literacy level, poverty issues, so economic factors come in, cultural, some myths and misconception, but environmental could be anything, also geographical access to the health facility. But this is more on the demand side. On the supply side, it's been said quite widely here in terms of skills for the personnel. So in terms of factors here, you need to equip adequately in terms of human skills, but also equipment within the facility. I think Dr. Chapa said it very well, so I'll just stop there. Thank you.
Thank you so much, Dr. Florence. And finally, but not least, I would like to welcome Ellen. I give you 1 minute to respond to question directed to you. Thank you.
Thank you. I responded in the chat, but essentially the key differences, as Emmanuel and Gaspri alluded to, is that Tanzania is a medical center-based model, so we just provide all the fistula surgeries out of Buganda Medical Center. in comparison to Uganda, where it's a medical camp model, which is able to do different medical camps across different districts, whereas we only operate out of one, which means the amount of surgeries that we're able to provide out of one centre is going to be less than what the Uganda team across a whole region. But the benefits of that is that Buganda's centre has become almost like a centre of excellence within the region to provide fistula surgeries. Also, in addition, the Tanzania team does a lot. The Tanzania project does more training for mentorship for the surgeons that provide the fistula treatment, and then also we have a larger amount of. The Tanzania project has a greater amount of fistula ambassadors rather than working with the village health teams, which is what the model in Uganda is. And just finally, we in the Tanzania project are more focused on individual grants for the socio-economic support of fistula survivors due to the remoteness of where some of the clients live, whereas the socio-economic support in Uganda is mainly focused on village saving groups. So yes, thank you.
Hey, thank you so much, Ellen, for good response. Now, I take this opportunity really to thank you, all audience, for your active participation, very interactive. Now, I would like to welcome Dr. Isa, our Director of Program here at Amref West Africa in Tanzania, a distinguished medical doctor and public health specialist, and she has a very strong strength in nurturing organization knowledge management while driving accountability, a trustworthy, visionary, research-oriented leadership. Please join me to welcome Dr. Isa to give us a closing remark, including key takeaways for today. Thank you, and please, Dr. Isa, you're welcome.
Thank you very much, moderator, Dr. Serafina, for your very nice words, and distinguished colleagues, partners, and friends. As we come to the end of this insightful and powerful session, I want to sincerely thank each one of you for your time, contributions, and commitment to the cause of ending obstetric fistula in Tanzania. Today's webinar has not only reaffirmed the devastating impact of fistula on the health, dignity, and socioeconomic status of women and girls, but also underscored the immense potential we hold collectively to bring change. We have heard moving stories of resilience, best practices from across region, Uganda, Tanzania, and data-driven strategies that are driving progress in prevention, treatment, and reintegration. The discussion around the alarming rise of iatrogenic fistula has rightly reminded us that while we celebrate the past gains, we must also remain vigilant about emerging challenges, particularly those that are entirely preventable through investment in surgical training, health systems strengthening, and clinical accountability. What stands out most from our discussion today is this: eliminating fistula is not a distant dream. It's not a distant dream, it is a realistic and achievable goal when we work together across sectors, levels, and geographies. So let me share 4 key takeaways as we wrap up. 1, collaboration is not optional, it is essential. Government commitment, community ownership, donor support, and technical expertise must continue to converge if we are to deliver quality, equitable, and sustainable fistula care services across the country. Number 2, survivors must remain at the center of our efforts. Beyond surgical repair, true healing requires reintegration, economic empowerment, psychosocial support, and a collective effort to dismantle the stigma and isolation that often follows fistula survivors. Number 3, innovation and accountability go hand in hand. Where is digital tracking of fistula cases, community engagement models like loyalty program, or capacity building for safe surgical practices, we must continually invest smart solutions while holding ourselves accountable for the results. And number 4, increase domestic health investment. We have to continue advocating for this. It is imperative for the governments to really think and consider boosting funds for accessible, timely, and respectful reproductive health services. I was very astonished to hear the presentation from our government colleague when they're talking, really showing, demonstrating commitment, very high level of commitment. And I'm glad that there isn't a fistula strategy that is under development. And we're looking forward to have that and support implementation as much as possible. So to our esteemed speakers, Dr. Phineas Sospita, Gasperi Misungwi, Emmanuel Ebitu, James Chapa, Dr. James Chapa, Ms. Ellen Gambo, thank you for your clarity, your expertise, and for inspiring us with practical, scalable models. Your voices have enriched this dialogue tremendously. And to our partners at the Ministry of Health, PRAJ, and fellow organizations across the region, thank you for walking this journey with us. Amref remains committed to continuing this work in partnership and to bring hope and healing to every woman and girl living with or at risk of obstetric fistula. And finally, to everyone who joined us today, thank you. Thank you so, so much for your time really to be in this webinar for 2 hours. So let us carry forward the energy of today's discussion into concrete action so that the vision behind the webinar's theme, her health, her right, shaping a future without fistula, becomes a reality within our lifetime. Together we can and we will end fistula. We will end obstetric fistula. We will end iatrogenic fistula. We will end any fistula in Tanzania. Thank you and stay well. Thank you so much, moderator. Over to you.
Thank you very, very much, Dr. Isa. That was so nice of you. Very good conclusion and very good key takeaways. I also take this opportunity to thank you and thank you all speakers again. And most importantly, all the participants who have participated in today's webinar. Thank you so, so very much for your time. For those who are still having questions, please don't forget to write to us. Because of time, we are wrapping up. We don't have more time to discuss. We apologize for that, but please email to us and reach to us. Always we respond to you. Thank you so much. Our government also who have participated and really shared all the priorities for fistula, ending fistula by 2030. Thank you and have a good time.